Hi, my name is Dr. Reid DeLacy. I'm Associate Professor of Neurosurgery and Radiology and the Director of Neurointerventional Spine at the Mount Sinai Health System. I'm going to give you a short talk on the V-Strut vertebral implant system and its intended use in the treatment of vertebral fractures. So we're going to get straight into it with the product and its indications. V-Strut is a vertebral implant. It's indicated for the use and treatment of vertebral fractures in the thoracic and lumbar spine from T9 to L5. It's indicated for fractures that are both osteoporotic and neoplastic in nature. It's intended to be used in combination with Technomed F20 bone cement, PMMA bone cement for vertebroplasty and kyphoplasty, and this is through the PMMA. It's a Class 2 device according to the FDA classification, and it's made of a PEEK polymer. The type of fractures that we're looking to treat with this are Gennett classification grade 1 and grade 2. These are fractures that have mild wedge deformity or biconcave deformity or moderate wedge or biconcave deformity. And the rationale for this is the device has to have space and the right trajectory to make it into the vertebral body. The biomechanical principle underpinning the device is as follows. This is a PEEK polymer implant, and it's intended to approximate as close as possible the biomechanical properties of normal bone. It uses pedicle anchorage to share loading between the anterior and the posterior column, and the intention is full vertebral reinforcement with 360-degree securement of fractures and the vertebral body itself. In the normal spine, we see biomechanically that 60% of the axial load is transmitted through the anterior and middle column and 40% posteriorly, but as we age due to kyphosis, this axial loading increases in the anterior and middle column to 80%, and this is why we see a progression in compression fractures and deformity in the aging, and also leads to one of the risks of refracturing in patients that have had previous fractures or severe osteoporosis. The intent of the device is to act as an anchoring system to rebalance and redistribute this load to the posterior column with the intent of decreasing subsequent fracture risk and further deformity of the treated vertebrae. Finite element analysis in an osteoporotic model shows really quite impressive redistribution of load in the target vertebrae. So when we look at these color renderings, the first image on the left shows the distribution of stress within the anterior, middle, and posterior column of a 3 vertebrae system without using an implant in an osteoporotic model. In the center, this is with the V-Strut PEEK implant, and you can see that there's a decrease in the distribution of axial loading and force transmitted through the anterior, middle, and posterior column at each level when you compare to without the implant. And when this was repeated using an implant of similar appearance and design but made with titanium, you can actually see that the axial load and distribution of force is increased. And this is because titanium or metal implants don't have the ability to redistribute load appropriately, and they're too rigid as opposed to PEEK implants, which more closely approximate that of normal bone. We have a publication in process which is outlining this in greater detail. So we're going to move on to some clinical experience with a few cases. So currently we have 17 patients where the device has been implanted, 12 female and 5 male, with an average age of 64 years. There are 8 osteoporotic fractures treated, 6 neoplastic fractures treated, and 3 traumatic fractures. And the distribution is 5 cases at L1, 2 cases at L2, 6 cases at L3, 3 cases at L4, and 1 case at L5. Baseline VAS at time of operation is 8 with a standard deviation of 3.4, and that's recorded in 15 patients. And the baseline Oswestry pre-treatment is 43.8, so at least moderate to severe disability with a standard deviation of 20.9, and that's in 11 patients where data was available. Clinical centers is distributed between the United States, France, and the Middle East. 13 patients have had this implant implanted under general anesthesia with 4 under MAC, and all implants used were of the 5.5 diameter variety. Cement, in terms of the cement used for these cases, 10 patients were treated with the F20 Technomed cement, 3 patients with Vertiplex, 2 patients with Verticem, 1 patient with Kyphon, and 1 patient with Osteopal V. Quantity of cement on average is 5 cc. Procedure duration is 45 minutes from puncture to skin closure, and hospital stay on average, median is 2 days with a standard deviation of 15.9, and that's an N of 15. There are no intraoperative complications. There was a couple of cases of asymptomatic cement leakages without consequence, and one patient developed a subcutaneous hematoma at the access tract, which resolved with conservative care. And in terms of implanting, this is a straightforward technique involving access needles, a K-wire technique, an access channel, and then creating the pathway within the bone to deploy the implant and cement through the implant. It's really quite a straightforward device to use. In terms of outcomes, as we talked about, baseline VAS scores are up around 7 to 8. In 15 patients on hospital exit, this drops down to less than 2 in the 8 patients where data is available. And at 2 months, again, this is closer to 1. For oswestry, baseline oswestry, again, as we said, really quite significant, severe, up in the 40s in 11 patients, and in the 8 patients where data is available at 2 months, it drops down to the mild disability below 20. So really quite impressive pain and functional outcome scores that mirror what we see in patients getting cement. First case is a female 72-year-old with osteoporosis and a fracture of L3. On the left, you see the post-procedural AP and lateral x-rays with the device. The visible portions of the device are the tantalum markers, which are located at the posterior aspect of the pin and the anterior aspect of the pin, and that allows you to identify where it is in the vertebral body. And the cement distributed between the anterior and middle column, going from the superior to inferior end plate, as demonstrated on the CT scans to the right. Another patient, this is a female 69-year-old with osteoporosis and an L3 fracture, again mirroring the same kind of results that we saw in the previous case. Again, with this, we could see cement tracking up the center of the implant. That's why we see that radio opacity linear signal tracking back through the pedicle. And again, nice distribution of cement. And really, the risk of cement leakage with this device should be less than we typically would see with routine vertebroplasty and kyphoplasty. Another case, and our final case, is a male 65 years old with osteoporosis and an L1 compression fracture. Again, this is again in class 1. Images on the left show the access channels, the initial access needles. This patient was initially managed during the procedure with balloon cavity creation, and then the V-Strut devices were placed subsequent to that with cement at the end. And again, we see a really nice distribution of cement running all the way to the dorsal aspect of the middle column with no leakage. And we have a 12-month follow-up showing no adjacent level fractures and stable deformity of the targeted vertebral body. So that brings us to the end of our presentation. In summary, this is a novel transpedicular device that's minimally invasive in its insertion. It's intended to provide more physiologic and anatomic reconstruction of a vertebrae and decrease the likelihood of further compression, fragmentation, and deformity of the target vertebrae, but also to decrease the risk of subsequent fracture at adjacent levels. And there are ongoing clinical trials currently in the United States examining outcomes, both functional and pain scales, and radiographic for this device. Thank you for your time, and enjoy the rest of the meeting.